Hello, my name is Lauren Thomas, and today I will be presenting my Doctor of Nursing practice project. The title is Normalizing the Conversation of Death and Dying, the Development of a Clinical Practice Guideline for Advanced Care Planning in Primary Care. I'd like to begin by thanking my committee, Dr. Gail Petroff, who served as my chair and offered consistent feedback and guidance throughout this process. I also thank Dr. Boniface Stegman and Dr. Norma Green for their thoughtful input and support in reviewing and evaluating my work. The purpose of this DNP project was to develop and evaluate an evidence-based clinical practice guideline to support primary care providers in initiating advanced care planning discussions with patients aged 65 and older. The aim was to create a structured, evidence-informed resource that promotes timely, value-based communication in the primary care setting. So, advanced care planning, or ACP, helps ensure that medical care aligns with the person's values and goals, especially when they're no longer able to communicate for themselves. Despite its importance, completion rates before the COVID-19 pandemic were low. In 2015 and 2017, only about 29% of adults aged 65 and older had completed all three components of ACP. These three components are a living will, a healthcare power of attorney, and documented discussions with providers. Also, more than 20% of older adults had not engaged in any form of ACP at all. And among the general U.S. adult population, only 36.7% had an advance directive on file. After the onset of the pandemic, there was a noticeable shift in perception. By 2021, over 57% of people said that they believed ACP was important, and nearly 60% reported having an advance directive. However, even with this increased awareness, many still lack completed ACP documentation, or there are a lot of people who have not discussed their preferences with a provider. This disconnect highlights the ongoing need for provider-led conversations in routine care. The need for effective ACP is growing rapidly, especially as the U.S. population ages. The number of adults aged 65 and older is expected to rise from 54.1 million to over 80 million by 2040. Life expectancy is also projected to increase from just under 80 years to nearly 86 by 2060. With increased longevity comes greater demand on the healthcare system. About 25% of years lived after age 60 involve illness or injury, and older adults account for the majority of healthcare costs and service utilization. These challenges are further compounded by provider shortages and access limitations, especially in rural areas. So, in my review of literature, I grouped the literature by strength of evidence. Level 1 included systemic reviews, randomized control trials, and well-established frameworks like VitalTalk, REMAP, and the trans-theoretical model of behavior change. These were the strongest sources and appeared in 12 studies. Level 2 included observational and retrospective studies found in 14 sources. Level 3 included mostly descriptive or cross-sectional studies with limited controls, and there were 4 sources that I found for that. This structure helped prioritize strong, evidence-based insights while still capturing diverse perspectives. After organizing the studies by level of evidence, I also graded their overall quality. Grade A studies were high quality with strong methodology, clear outcomes, and findings. These could be applied broadly. 16 studies met this standard. They often used validated tools, structured frameworks, and had large or diverse samples. Grade B studies had minor limitations like smaller sample sizes, limited generalizability, or reliance on self-reported data. 14 studies fell into this category, and this grading helped clarify not just what the literature said, but how much confidence to place in those findings. So, most of the sources were level 1 or 2, which adds to the credibility and applicability of the findings. The majority were also rated grade A or B, giving a strong and reliable foundation for the clinical guideline. Overall, the evidence consistently supported key strategies like integrating advanced care planning into routine care, improving provider communication skills, and tailoring interventions to meet the needs of vulnerable populations. My literature review revealed 3 main themes. The first one is that denial and discomfort with death are major barriers to advanced care planning. Second, that the absence of advanced care planning results in higher costs and often non-beneficial care. And third, that although guidelines exist, most are tailored to acute or oncology settings rather than for routine use in primary care. This project sought to address that gap. So the first theme, barriers to advanced care planning, includes denial of death, cultural stigma, and emotional avoidance, not only among patients but also among providers. Many providers feel unprepared to lead these discussions due to limited training or time constraints in the primary care setting. Additionally, low health literacy and discomfort with the topic contribute to delays or missed opportunities. The second theme was the consequences of inadequate advanced care planning. When these conversations don't happen, patients are more likely to receive unwanted or non-beneficial interventions, particularly near the end of life. This can lead to emotional distress for families and contributes to higher healthcare costs due to unnecessary or aggressive treatments. The third theme was that existing guidelines, while helpful, are often developed for specific situations, like cancer care or crisis events such as the COVID-19 pandemic. Tools like the Golden Standards Framework and REMAP are valuable, but were not designed for routine use in primary care, where providers often have limited time and different patient dynamics. So, the literature clearly points to a need for standardization. Primary care providers need a structured yet flexible approach to initiating advanced care planning. Research supports the use of tailored communication strategies that align with patient readiness, which improves both the quality of conversations and the likelihood the ACP will be completed. This project was guided by the trans-theoretical model of behavior change, which outlines how people move through stages of readiness when adopting new behaviors. In the context of advanced care planning, some patients may not be ready to have the conversation, while others are prepared to act. This model supported a patient-centered approach to the guideline, allowing providers to tailor conversations based on where the patient is at, whether that's pre-contemplation, contemplation, preparation, action, or the maintenance stage. This model helped shape a flexible guideline that providers can use to meet patients where they are in the process. To evaluate the quality of the clinical practice guideline, I used the Agree-To instrument, which is a validated tool designed specifically for assessing clinical guidelines. 5 interdisciplinary stakeholders independently reviewed the guideline and rated it using a 7-point Likert scale. Their evaluations were based on 6 domains: scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. This comprehensive framework helped ensure the guideline was assessed not just for content, but also for usability and credibility in clinical settings. This project followed a non-intervention descriptive design as part of a practice improvement initiative. The goal was to develop and evaluate an evidence-based clinical practice guideline for advanced care planning in the primary care setting. The guideline was informed by a comprehensive literature review and evaluated by a panel of interdisciplinary stakeholders. The project took place in a rural primary care environment where provider access and time limitations often make advanced care planning more challenging. Rather than testing an intervention, this project focused on creating a tool that could eventually be implemented into practice. The stakeholder sample included 5 interdisciplinary stakeholders who participated in the evaluation of the clinical guideline. The stakeholders were composed of 2 nurse practitioners, 2 medical doctors, and 1 social worker. The interdisciplinary mix allowed for broad, well-rounded feedback and ensured that diverse clinical perspectives were represented in the guideline appraisal. Once all 5 stakeholders completed their evaluations, I calculated domain scores using the Agree-To scoring formulas. Each of the 6 domains received a scaled score ranging from 91 to 99%. And all of those scores were exceeding the pre-established quality threshold of 85%. The highest scores were in applicability and editorial independence, suggesting the guideline was seen as both relevant and unbiased. The lowest scoring domain was clarity of presentation at 91%, which still indicated strong performance but suggested minor opportunities for refinement in formatting or layout. The stakeholder evaluations revealed strong support for the guideline's quality. The highest domain score was applicability, rated at 99%, indicating that the guideline was seen as highly relevant and feasible for use in primary care. Editorial independence scored 97%, suggesting that reviewers viewed the guideline as objective and free from bias. The lowest domain score was clarity of presentation at 91%, and this still exceeds the quality threshold, but points to some minor improvements needed in formatting or organization. Overall, the guideline received high marks and strong stakeholder support. All 5 stakeholders indicated they would recommend the guideline for use without modifications. This suggests that the tool is methodologically sound and practically relevant for clinical use. This project was limited by its small sample size and lack of real-world implementation. Because it was a non-intervention study, the guideline was not implemented into clinical practice. so I was not able to assess its real-world impact on advanced care planning behaviors. Also, the findings may not be generalizable to other settings outside of rural primary care. Finally, although stakeholder feedback was anonymous, there is always a possibility of bias based on personal or professional predispositions. The results of this project suggest that the clinical guideline is both relevant and feasible for use in the primary care setting. All stakeholders recommended it for implementation, which supports its potential to fill a current gap in practice. However, several barriers to adoption still exist. Providers often face time constraints and heavy workloads, which may limit their ability to engage in advanced care planning, especially without organizational support or workflow integration. That said, these conversations are particularly important in rural settings where access to palliative care and specialty services is limited. A structured, evidence-based guideline can help primary care providers initiate meaningful conversations earlier and more consistently, improving outcomes for both patients and families. This guideline has meaningful implications for nursing and primary care practice. It can enhance provider confidence, improve patient-provider communication, and promote person-centered care. In rural communities where access to palliative care may be limited, equipping primary care providers as though they are frontline workers, because they are in the primary care setting, equipping them with a practical tool like this can significantly improve the coordination and quality of care for older adults. In summary, this project successfully developed and evaluated a high-quality, evidence-based advanced care planning guideline that fills a gap in primary care practice. It offers a stepwise, evidence-based approach to initiating these important conversations with potential for meaningful clinical impact once implemented. The guideline met rigorous quality standards and received strong stakeholder support. Implementation efforts should focus on addressing workflow integration, provider engagement, and patient education to optimize effectiveness. Future research should examine the guideline's impact on advanced care planning completion rates and patient outcomes. These are a few key references that informed the project. Thank you for your time and attention. I appreciate the opportunity to share my findings with you today. And I welcome any questions or feedback that you may have.